Okay, so now the next major topic we're going to go to is the topic of lymphomas. And we're going to talk in detail about this, about Hodgkin's lymphoma and a non-Hodgkin's lymphoma. But before we go on, firstly let's define what is a lymphoma. We can say a lymphoma is a collection of lymphoid malignancies where malignant lymphocytes accumulate at the lymph nodes and at lymph tissue. It's a group of malignancies where the lymphocytes accumulate at the lymph nodes and lymphoid tissue, therefore causing a lymphadenopathy. Okay, so malignant lymphocytes accumulate at lymph nodes and lymph tissue, therefore causing a lymphadenopathy. Okay, so this is typically what we can say. Now to diagnose this, the typical way is to do a biopsy. You biopsy the lymph node and you'll see whether the lymphoma is present. And you'll see that a lot of them are from B-cell origin. So a lot of the lymphomas are of B-cell origin. Okay, so let's just make a note of that. Biopsy, important. And B-cell origin, usually. So most of them are of B-cell origin. Now, when we classify the lymphoma, especially the non-Hodgkin's lymphoma, there's a specific way we can do this. We can say something is a low-grade tumor or a high-grade tumor. Okay, and this depends on the proliferation rate. So we look at the proliferation rate and we see if it's high, it's going to be a high-grade tumor. If it's low, it's going to be a low-grade tumor. So classification. We can have a high-grade, or we can have a low grade. Okay, and this is all going to depend on our proliferation rate. Proliferate. Okay, and depending on this, especially on this, it's going to tell us whether we have a high grade lymphoma or a low grade lymphoma. Now, if we start by talking about the high grade lymphoma, we can say in this kind, the cells are going to divide very rapidly. Firstly, high cell division. So division is rapid. Rapidly. In this situation, we can say that it can present weeks before the diagnosis. So it can be there weeks before the diagnosis, not months, not years, because the proliferation rate is so high. So weeks before diagnosis. And in a high grade, most importantly, we can say it's life-threatening. In a lot of the situations, it's going to be a life-threatening situation in a high-grade lymphoma. So life-threatening. If we talk, however, about a low-grade lymphoma, we can say it divides very slowly. It's not a rapid growth. It can be present for months or even years before the diagnosis. And usually, it's not life-threatening. It's a complete opposite. Divides slowly. Months, let's say months before diagnosis. And we can say it's not life-threatening. So it's much slower and it's much less serious than a high-grade lymphoma. High-grade lymphoma is very bad. All of these can be staged using something called the Ann Arbor classification. Okay, so now we have a brief idea about lymphomas. We know what a lymphoma is, we know how it's diagnosed, we know that a lot of them are of B-cell origin, and we also talked a bit about the classification of a high-grade lymphoma to a low-grade lymphoma. Now just to go into a specific kind, which is a Hodgkin lymphoma, and then later on we'll come into a non-Hodgkin's lymphoma and talk about the differences. In this case we can say it's a malignant proliferation of lymphoid cells, just like we said for a normal lymphoma. And the most important thing is to know the histological hallmark of Hodgkin's lymphoma, which is the presence of Reed-Sternberg cells, specific cells called Reed-Sternberg cells. The histological hallmark is Reed-Sternberg, specific to Hodgkin's lymphoma cells. Okay, so specifically what we can say a Reed-Sternberg cell is it's malignant, it's very large, and it's a lymphoid cell of B cell origin. Malignant, large lymphoid cell of B cell origin. So, malignant, large, and it's of B cell origin, just like we said most lymphomas were. So it comes from B cells. Most lymphomas come from B cells, B cell origin. The Reed-Sternberg cell itself usually isn't present in high numbers. So it's a very small number of Reed-Sternberg cells, but they're surrounded by certain other cells. And these cells can be T lymphocytes, they can be non-malignant, so completely healthy T cells. We can have eosinophils, and we can have plasma cells. Okay, so all of these can surround the Reed-Sternberg cell. Now, just to talk about the types of Hodgkin's lymphoma, we can split into two main categories. We can say we have the classical Hodgkin's lymphoma, which we can split into four different types, four different histological types, depending on the appearance of the Reed-Sternberg cell and the appearance of the surrounding cells. So that's number one, a classical Hodgkin's lymphoma. Okay, and we say in this situation we have four subtypes depending on the morphology of the Reed-Sternberg cell. The second type we can have is a nodular lymphocyte predominant Hodgkin's lymphoma, a nodular lymphocyte predominant. Nodular lymphocyte predominant. Okay, so this is not a very common kind. It makes up only 5% of the Hodgkin's lymphoma. It's very slow growing, it's very localized, and it's very rarely fatal. So slow growing, rarely fatal. Okay, but like I said, it's only one that makes up 5% of the Hodgkin's lymphoma. So we can have classical or nodular lymphocyte predominant Hodgkin's lymphoma. Hodgkin's lymphoma, the histological hallmark is a Reed-Sternberg cell. Reed-Sternberg cells are going to be surrounded by other cells, T cells, plasma cells, eosinophils. These Reed-Sternberg cells are malignant, large, and of B cell origin. To classify this, we have the classical type, which we have four subtypes depending on the appearance of the Reed-Sternberg cell and the surrounding cells, or the nodular lymphocyte predominant type, which only makes up 5%, and is slow growing, is localized, and is rarely fatal. So clinically, what are we going to see in a Hodgkin's lymphoma? What are the main things we should look out for? We know, of course, in a lymphoma, lymphadenopathy is very important. So in a lot of situations, we could have a lymphadenopathy, and this is going to be a painless, rubbery lymphadenopathy, mostly in the neck, maybe in the supraclavicular fossa also. So painless, rubbery lymphadenopathy. Typical sign. Also, patients may present with splenomegaly, a severely increased size of the spleen. Splenomegaly. Also, in certain types of Hodgkin's lymphoma, in the nodular sclerosing type, which is what we talked about, the nodular type before, we can have a mediastinal mass. A mediastinal mass can develop, and this can cause the patient to cough and cause breathlessness because of the compression of the lungs. So coughing and breathlessness is also a possibility, and detecting the large mediastinal mass on imaging, weightless. Okay, but only in certain kinds of Hodgkin's lymphoma this is going to be present. In a lot of the other kinds there'll be no mediastinal mass. Also importantly, non-specific symptoms, things like weight loss, night sweats, fever, very non-specific symptoms might be important to look out for. So non-specific. Okay, so mainly lymphadenopathy, splenomegaly, cough and breathlessness if there's a large mediastinal mass in certain kinds, and non-specific symptoms, weight loss, night sweats, fever. They say that the spread of this malignity from lymph node to lymph node is contiguous, and it goes from lymph node to lymph node which are adjacent or which are close by. So it goes to the close lymph node first, then slowly spreads around the body. Okay, so in this we can say contiguous spread. Contiguous spread. Okay, so to the adjacent lymph nodes, spreading within that region first before going to any other areas. And of course we have to stage this via the Ann Arbor classification. Now to investigate this disease we're going to have to do a large number of tests because the disease can spread. It can go from lymph nodes to lymph nodes around the body and can affect a lot of the different organs. So investigations, of course, first is first, full blood count. Okay, and it's possible on a full blood count that we see a lymphopenia, a decrease in the number of lymphocytes, which is actually a poor prognostic factor. Okay, so lymphopenia is something that's not going to be good in this situation, so we don't want lymphopenia. It's possible that the ESR, the erythrocyte sedimentation rate, may be increased because of the inflammation. If the disease is spread to the liver, then possibly liver function tests might be important. So LFTs, if it's spread. Other tests, of course, we talked about the large mediastinal mass causing cough and breathlessness, so it's important to have a chest x-ray to see if there's any mediastinal mass. Possible CT scan to stage the disease to see how far it's spread. So x-ray for the mediastinal mass and CT scan to stage. Okay, so these are typical tests. We might have to do also other tests to ensure that other organs aren't affected. But obviously most importantly to diagnose this, we have to do the lymph node biopsy. Okay, and this is going to be done with radiological guidance, but it has to be done. So a lymph node biopsy. So clinically, we said painless lymphadenopathy is very important. Painless rubbery lymphadenopathy in the neck or supraclavicular. We can have a mediastinal mass in certain kinds. We can have splenomegaly. We can have non-specific symptoms like night sweats, like weight loss. Very important to check for. It's a contiguous spread from adjacent lymph nodes, from lymph nodes that are connected. And you have to look at an Ann Arbor classification to classify this properly. Investigations. We have to do widespread investigations, full blood count to see if there's a lymphopenia, liver function test to see if it's spread to the liver. We can do a CT scan to see if there's any, to see the staging of the disease, how far advanced is it, an X-ray to see if there's a mediastinal mass, to possibly to say it's a certain kind of Hodgkin's lymphoma. And of course a lymph node biopsy is very important to diagnose the disease and to confirm suspicions. We can say that it very much depends on the staging of the disease, whether it's very early or it's late. In an early stage, for example, stage 1A or stage 2A, then radiotherapy and chemotherapy can be given. Early on, before they used to give only radiotherapy, but apparently after tests they found that it was more successful with radiotherapy as well as chemotherapy. So what we're going to do is discuss radiotherapy briefly, and then just go on to the chemotherapy and talk about the specific regimen which is used there and used in Hodgkin's lymphoma. So let's start with radiotherapy on this side, and we'll have chemotherapy on this side. Okay, the radiotherapy is reasonably brief. Okay, now we can say any woman who's being exposed to radiation at the chest is of course going to increase the risk of breast cancer, of that person developing breast cancer. So it's very important to have a strong breast cancer screening program. Okay, an effective breast cancer screening program. Okay, so that has to be in place. Secondly, anyone with lung irradiation, especially smokers, are going to increase the chances of lung cancer, especially smokers. So increase in lung cancer in smokers when we have lung irradiation. Okay, so two things to keep in mind: breast cancer screening program and lung cancer in smokers increased chance from lung irradiation. So now chemotherapy. Like we said, in an early stage they used to only use radiotherapy, apparently no confirmation, but now with chemotherapy they find it's more effective. With chemotherapy we have to talk about a specific regimen, the ABVD regimen. Okay, now this consists of 4 drugs which are supposed to be very effective and very widely used in the UK. I'm not sure about the States, but it's very widely used in the UK. And the drugs are, alright, bear with me here, doxorubicin, bleomycin, vinblastine, and dicarbazine. Alright, so it's a successful treatment. It's supposed to be very effective in Hodgkin's lymphoma, and it gets a lot of patients into remission. Like I said, it's very much used in the UK, and I think also in the States. However, the downside is that with this regimen, it can cause cardiac problems and it can cause pulmonary problems. So it's not uncommon to have cardiac problems and pulmonary problems because of this. And once the treatment is given, of course you have to monitor the patient, see what the situation is. You have to possibly give regular CT scans, possibly a PET scan is an option, to monitor how the person is reacting to this ABVD regimen. Okay, so let's say it's in the UK, it's used, CT scan / PET scan is possible, and it's very effective, but can cause cardiac or pulmonary problems. Okay, so if it's been used for a long time, possible cardiac and pulmonary problems. Okay, so this is in a early stage disease, in a not very advanced disease, radiotherapy and chemotherapy. Now they say that if it's a very advanced disease, if it's very late, an advanced stage disease, we give chemotherapy alone with a possibility of introducing radiotherapy if it doesn't work. So they say 6 to 8 cycles of this ABVD regimen have to be given if it's an advanced stage disease. And if there's no reaction after all of this, if it's an advanced stage and still there's no reaction, of course you have to consider a bone marrow transplant in certain individuals that qualify for this. Okay, so let's say this is an early stage. Early, we're going to give chemotherapy and we're going to give radiotherapy. In a late stage, we'll just give the chemotherapy with a possibility of radiotherapy, but they say it's just with the chemotherapy, and that's 6 to 8 cycles of this ABVD regimen. 6 to 8 cycles of the ABVD regimen. Okay, now the prognosis. So we talked about the early stage, we talked about the late stage. The prognosis, we can say it's a very, very good prognosis usually. 90% of patients go into remission, and something like half of those patients are cured. So they're completely cured of everything to do with the the disorder. Even, so this is an early stage. If it's an advanced stage, again, the prognosis is quite good. Something like 60 to 70% can go into remission, and just under that can be cured. So the prognosis of this disorder, a Hodgkin's lymphoma, is actually very good. Okay? So prognosis. In an early stage and a late stage, the prognosis is actually quite good. So Hodgkin's lymphoma management, radiotherapy and chemotherapy in an early stage disease. We give both. Radiotherapy, make sure we have a good breast cancer screening program. Make sure we know that lung cancer has an increased chance if there's lung radiation, especially in smokers. Chemotherapy, ABVD regime, doxorubicin, vinblastine, bleomycin and dacarbazine. Very important, you monitor this patient once this is enforced with a CT scan or a PET scan. Can possibly cause cardiac problems and pulmonary problems, so be on the awareness, be on the lookout for this. In the early disease, we treat with chemo and radiotherapy. Apparently now it's more effective. Late, just chemotherapy, 6 to 8 cycles, with the possibility of radiotherapy being introduced. The prognosis of Hodgkin's lymphoma is very good, even in a late stage disease. So I think that's enough for Hodgkin's lymphoma, and I think we can now go on to discuss the non-Hodgkin lymphoma. In a non-Hodgkin lymphoma, we can say it's a proliferation of either B cells or T cells. So in 70% of the cases, we have a B cell proliferation, and in 30% of the cases, we have T cell proliferation. So proliferation of either B cells or T cells. The B cells, we can say, are 70% of the time it's B cells, and then 30% of the time we have T cells. So proliferation in Hodgkin's, we said it was B cells. In non-Hodgkin's, it can be a B cell or a T cell. Again, just like the others, it can appear in the elderly more commonly, and we specifically spoke at the beginning about a classification. We said high-grade lymphoma and low-grade lymphoma. This is especially important in the non-Hodgkin's lymphoma. We said we have high-grade and we have the low-grade. Okay, and we specifically mentioned some features. I won't write everything again, but we said for the high-grade, high proliferation rate, we're going to have symptoms occurring very early on before the actual diagnosis, and it's going to be potentially life-threatening. For the low-grade kind, it's going to have a low proliferation rate. Usually it can be asymptomatic for many months, and usually it's not life-threatening, so it's not as serious as the high-grade lymphoma. So it's important we know this grading system. We have this in mind, especially for the non-Hodgkin lymphoma. Okay, now for the etiology. So why does a non-Hodgkin lymphoma develop? We can mention two main things. Firstly, we can mention chromosomal translocations. So for the etiology, one, chromosomal. Okay, so certain kinds of lymphoma, for example, a follicular kind of lymphoma, can be linked with a certain translocation. In a follicular type, we have a translocation with chromosome 14 and chromosome 18. So because of this translocation, it's going to inhibit cell death, and it's going to cause the development of a non-Hodgkin lymphoma. So, for example, follicular lymphoma, is a translocation with chromosome 14 and chromosome 18. Okay, so that's the first thing. We can talk about chromosomal translocations messing up the cell death process. Secondly, we can talk about viral infections. So certain viral infections can be associated with a non-Hodgkin's lymphoma. Infections like HIV, very importantly, like Epstein-Barr. I think also HCV could be one. So HIV and Epstein-Barr we'll keep in mind. So viral infections another possible thing to keep in mind, especially HIV, and that will come onto that in the testing, and possibly Epstein-Barr. Okay, so EBV infection. Okay, so these are the typical things we need to look for on the etiology. So clinically, what are we going to see in a non-Hodgkin's lymphoma? Clinically, typical things. Again, it's a lymphoma, so number 1, lymphadenopathy. Number 2, just like in a Hodgkin's lymphoma, we should look out for a splenomegaly or possibly an hepatosplenomegaly, depending on how spread the disease is. So spleno/hepato splenomegaly. Okay, possibly also we can have bone marrow involvement. In some situations the bone marrow is affected, anemia, bleeding, infection rates are increased, and this is especially in the low grade diseases. So bone marrow involvement. Okay, and especially in the low grade. In about half of the cases of low grade non-Hodgkin's lymphoma, we can have bone marrow involvement. Also possible is compression syndromes in very severe cases, and very rarely we have compression syndromes that can cause ascites, that can cause gut obstruction, that can cause spinal cord compression. So only in rare cases. In rare cases, compression syndrome, spinal cord, gut obstruction, ascites. Okay, so these are typical things that we should look out for clinically when assessing someone with a non-Hodgkin's lymphoma. Investigations. Okay, so for investigations it's going to be very similar to a Hodgkin's lymphoma. So look back at the Hodgkin's lymphoma tape and just add on a few other investigations. Okay, so let's say investigations, Hodgkin lymphoma plus more. Okay. Now we said in this situation we can have B cells or T cells. So it's important to do an immunophenotyping to know whether we're dealing with B cells or T cells. So number 1, immunophenotyping. Okay, we'll determine whether it's a B cell from a proliferation or a T cell proliferation from this immunophenotyping. We can also look at uric acid levels, possibly because it's an increased cell turnover. And importantly, we possibly have to do HIV testing, because we said with this condition, it's possible viral infections can be the reason why this is developed. So if the risk factors are there, then possible HIV testing. HIV test, if possible, risk factors. If. Okay, so not in every situation we're going to do HIV testing. Okay, so just a quick word about the management now, a management of a non-Hodgkin's lymphoma. We said that it's very important to know the grade of the lymphoma, whether it's a low-grade lymphoma or a high-grade lymphoma. In a low-grade lymphoma, we have a low proliferation rate, high-grade, high proliferation rate. It's important, I don't think we mentioned it before, in a low-grade lymphoma, you have the potential to, no, you do not have the potential to cure. But in a high-grade lymphoma, you have the potential to cure. I'm not sure why that is, but in a high grade, you do have the potential to cure. Okay, so if a patient has no symptoms and has a low-grade lymphoma, possibly you can watch and wait and give no therapy. No symptoms, no therapy. Watch and wait. But if the person does develop symptoms, then of course we have chemotherapy, we have radiotherapy as options. So option number 1, option number 2. Chemotherapy can be with a drug we mentioned before, which is chlorambucil. I'm not sure how successful that is, chlorambucil. And radiotherapy can be given in certain situations, especially I think in a stage 1 disease, a very early on localized disease. Radiotherapy can be given. A third kind of treatment, an interesting one, is called monoclonal antibody therapy. And basically what we do is we give antibodies that target surface antigens of the tumour cells. So the tumour cells have surface antigens, and the antibodies are going to target these antigens, and they're going to induce apoptosis of the cell. Okay, so this is monoclonal antibody therapy. And specifically we can talk about a drug called rituximab, which is an anti-CD20 antibody, and it's supposed to have a very successful effect. So monoclonal antibody therapy. Okay, and we can specifically, so let's say there's antibodies against that target surface antigens on tumor cells. Okay, when this happens, what we want to do is induce apoptosis. Okay, so this is going to be the effect of this monoclonal antibody therapy, and we said we have this drug rituximab with an X, and this is an anti-CD20 antibody. Of course chemotherapy, of course radiotherapy, but monoclonal antibody therapy with rituximab is a big option, and it has a high success rate. It has a good response in over 60% of cases, so a good chunk of the population with non-Hodgkin's lymphoma have a good response with rituximab, greater than 60%. Okay, now in some situations rituximab is not going to be given alone. It's usually given with other drugs, a cocktail with rituximab, with cyclophosphamide, which we mentioned before, vincristine, and also corticosteroids in the form of prednisolone. Okay, and this is going to make up something called, let's do it in a better colour, RCVP regimen. Okay, the RCVP regimen. It's going to be made up of rituximab, it's going to be made up of cyclophosphamide, it's going to be made up of vincristine and prednisolone. These 4 drugs together are going to make this RCVP therapy for non-Hodgkin's lymphoma. Rituximab, cyclophosphamide, vincristine, and prednisolone. Okay, so all these in combination, they say has a high success rate in treating a non-Hodgkin's lymphoma. All of these together. Now, of course, the 4th option, which we talked about before also, is of course a bone marrow transplant. So if the person qualifies, you can give a bone marrow transplant. So it's another possibility. 4th possibility, bone marrow transplant. Okay, so these are the main options in the management of a low grade. This is for low grade non-Hodgkin's lymphoma. Chemotherapy, radiotherapy, monoclonal antibody therapy with specific antibodies targeting antigens, and an anti-CD20 is rituximab, 60% success rate, very, very successful, and can be used in combination with other drugs in RCVP regimen with rituximab, cyclophosphamide, vincristine, prednisolone, and a 4th option is with a bone marrow transplant, and this is for a low-grade treatment of non-Hodgkin's lymphoma. Okay, so now the management of a high-grade non-Hodgkin's lymphoma. Again, the first things we can talk about are, so we said high-grade, high proliferation rate, but with a potential chance to cure. Now we can talk about radiotherapy again, and we can talk about chemotherapy again. Okay, just like in the low grade.